Everyone, let's take a look at this question. A 56-year-old man comes to the emergency department due to palpitations and lightheadedness. Over the last 2 hours, he has a history of hypertension but no other cardiac conditions and never before had similar symptoms. The patient drinks 1 to 2 alcoholic beverages daily but does not smoke cigarettes or any illicit drugs. Blood pressure is 132/76 mmHg and pulse is 116 per minute. Pulse is irregular. Cardiopulmonary examination is normal except for tachycardia, and resting ECG shows atrial fibrillation. The patient undergoes transesophageal echo which reveals normal cardiac anatomy, no intracardiac thrombus. Electrical cardioversion is performed. After the intervention, sinus rhythm is restored and amiodarone therapy is begun to maintain that normal sinus rhythm. Which of the following cardiac electrophysiologic changes are most likely to occur in this patient due to medication? So this patient had atrial fibrillation. They performed electrical cardioversion. In order to maintain the sinus rhythm after the cardioversion, they are giving amiodarone. And now they are asking us, because of amiodarone, what will be the changes in the ECG that we will see. In order to understand this question, we need to first understand the myocyte action potential. So, we will now talk about the myocyte action potential. So, this here is our myocyte action potential. We can see that at first, the cell is having a resting potential of minus 85 millivolts. So, this is our resting potential. And it is maintained because of voltage gated potassium channels, they are open, which is leading to potassium efflux. Since positive charge is leaving the cell, we are at a negative baseline, a resting potential of minus 85 millivolt. Then what happens is we get the first thing, which is the phase 0. Now what is happening in phase 0 is basically, this is our myocyte depicted here at the bottom, and in the myocyte we can see that voltage gated sodium channels, they open. As soon as the voltage gated sodium channel opens, what happens is the lot of sodium influx happens. Sodium enters, sodium is positively charged, so our action potential, it becomes positive and we get this depolarization phase. So phase 0 is the depolarization phase and it is because of sodium influx into the myocyte. Next thing that happens is we get the phase 1. Phase 1 is our early repolarization. What is happening in phase 1 is that voltage gated potassium channels, they open. Once the voltage gated potassium channel open, potassium starts moving out, and because of that potassium efflux, we get that initial repolarization where we are moving towards negativity, we are going down. So that's phase 1. Now while those potassium channels opened, voltage gated potassium channel, another thing that is very important happened, and that is our voltage gated calcium channels also opened. As soon as the calcium channel opened, calcium started moving inside the cell. Because calcium started moving inside the cell, it started balancing out that potassium efflux. So potassium efflux is balanced out by calcium influx and we get that plateau phase. That plateau phase is phase 2 and it is because of voltage gated calcium leads to, or it triggers, sarcoplasmic reticulum calcium release, and that leads to myocyte contraction. Once that happens, the voltage gated potassium channel, it remains open while this calcium channel, it closes. It has done its job. Now that calcium channel is going to close. This brings us to phase 3. In phase 3, what is happening is that the potassium is moving out. Potassium efflux is happening. So after the plateau phase of phase 2, once the calcium channel closes out, all we have are the potassium channel open. Because of this open potassium channel, potassium starts leaving, potassium efflux happens and we get the proper repolarization. So phase 3 is the repolarization. The action potential again starts moving towards this minus 85 resting action potential and ultimately we end up getting phase 4. Phase 4 is again the resting potential. So phase 3 is basically mediated by our very important slow delayed rectifier potassium channels. Okay, so phase 3, the potassium channels here, these are known as slow delayed rectifier potassium channels. Now in this whole myocyte action potential diagram, we can also see effective refractory period. What is effective refractory period? 200 milliseconds. This is that period during which another action potential cannot take place. Okay, so the time during which the cell cannot undergo another depolarization is basically our effective refractory period. And this is our myocyte action potential. Now next up we'll see how this correlates with our ECG. How does the action potential correlate with our ECG? Now what we need to understand is that while the phase 0 of the myocyte action potential is happening, it reflects on the ECG strip as QRS. So this QRS here is basically representative of the phase 0. Depolarization is happening and that is represented by the QRS on ECG. Another thing we need to know is that this whole phase 0, phase 1, 2 and 3, it is representing one full cycle of depolarization and repolarization. And again on the ECG strip, same thing is reflected. QRS is our depolarization phase, and then we get the T wave, which is representing repolarization. So this is how they correlate with each other. So if my phase 0 is being represented by the QRS complex, what if I was to give a drug that blocks out the sodium channel? Once I block the sodium channel, the entire curve of the action potential will shift to the right side. It will become something like this. Because I have blocked the sodium channel, so that part of the curve will be delayed, right? Now this will be represented on my ECG as the prolonged QRS. Like the QRS, it will prolong. This will prolong, right? So this is a very important concept, that whenever we are giving a drug that blocks the sodium channel, phase 0 will be delayed, and because of that delay in phase 0, the QRS is going to get prolonged. Another thing is that now if I was to give a drug that inhibited my potassium channel, phase 1 would be affected, phase 2 would be affected, phase 3 would be affected, and that would reflect on my ECG as the whole thing, from the starting of the Q wave to the ending of the T wave. The entire thing will get prolonged. So there will be QT interval prolongation whenever we inhibit the potassium channel. So while blocking the potassium channel, the entire curve shifts like this. And because the curve shifted like this, on the ECG, what will happen, this interval right here is going to get prolonged. It will get prolonged and it will also shift here like this. And this will be what we refer to as QT interval prolongation. Now the QT interval, earlier it was from here to here, and now it is from there to here. So this extra has been added and the QT interval has become prolonged, we can say. Okay, with that basic thing out of the way, what we now need to know is antiarrhythmics. There are two categories of antiarrhythmics which can alter your myocyte action potential. One is from class 1 antiarrhythmics. Class 1 antiarrhythmics are basically your sodium channel blockers. Okay, they are your sodium channel blockers. They will inhibit the sodium channel. Another category of drug, so a sodium channel inhibitor would shift my curve. The phase 0 will be prolonged and it will become like this, right? This is what happens when we prolong phase 0, which is the action of our sodium channel inhibitor. And what will happen if we were to give a potassium channel inhibitor? Well, that will affect our repolarization phase. such that it becomes like this, prolonged repolarization phase. That is a class 3 antiarrhythmics. And how are they represented on our ECG? Well, class 1A, the sodium channel inhibitor, phase 0. So it is going to prolong the QRS. It is going to increase our QRS duration. Okay, so this one here increases the QRS thing, and potassium one, this one increases our whole QT interval. So ultimately what ends up happening is class 1A drugs, they will inhibit your sodium channel and they will prolong your QRS complex, and class 3 antiarrhythmics will inhibit your potassium channel and they will lengthen the QT interval. Now the drug that was given in this question, which was our amiodarone. Amiodarone, we must know, is a class 3 antiarrhythmic. Class 3 antiarrhythmic means it is going to inhibit the potassium channel, prolong the QT interval. So in this question here, the QT interval is going to definitely be prolonged. Oh well, there is only one option with QT interval prolonged, so we already know it is going to be B. But let's see the other things also. Amiodarone prolong the QT interval. Okay. If the curve was to shift like this, just like we have been discussing with potassium channel inhibitors, the effective refractory period, what will happen to it? It will also increase. So another effect of amiodarone is that it is going to increase the effective refractory period. Now amiodarone is quite a amazing drug, because not only does it have potassium channel blocking effect, it also has activity just like class 1 antiarrhythmics. It is also a very good sodium channel blocker. So it is going to delay your phase 0, the depolarization phase, and because of that it is going to prolong your QRS. So just like here, amiodarone, because it has got class 1 properties also, it is also going to prolong your QRS complex. That is why here in this option we have prolonged our QRS, right? Another thing about amiodarone is that it acts like not just class 3, it is a class 3 antiarrhythmic with properties of class 1A. Another thing is that it also has properties of class 2 and class 4. So class 2 and class 4, they don't act on the myocyte action potential, they act on the nodal action potential. So if they act on the nodal action potential, they are going to be very useful in rate control. So it is having, just like class 2 antiarrhythmics, beta blocker properties, and beta blocker properties will lead to inhibition of the sympathetic stimulation in the conduction system, leading to rate control. And just like calcium channel blockers, it will also slow down your L-type calcium channel, leading to slow depolarization of the sinoatrial node and the atrioventricular node. So basically rate control also it is going to do. And whenever we are doing rate control, what will get prolonged? The PR interval will get prolonged. That is why for the answer of this question, what does amiodarone do? Amiodarone is a combo drug. Not only is it a class 3 antiarrhythmic blocking the potassium channel, it is also acting on the sodium channel. It also has properties of beta blocker. It also has properties of calcium channel blocker. So that is why it is going to not only do its potassium channel blockade, which leads to prolonged QT interval, it is also acting like a class 1 antiarrhythmic and leading to prolonged QRS duration. And it is also going to act like class 2 and class 4 antiarrhythmics, and it is going to prolong our PR interval. So the correct option here is B. So in summary, amiodarone is a class 3 antiarrhythmic. It is a potassium channel blocker. It prolongs the QT interval therefore. But it is also having some properties of class 1 and class 2 and class 4, which means it is also going to prolong the QRS complex, and it is also going to affect or increase our PR interval. And that's it about this question. Thank you.